All right. Well, by my clock, we've just turned over to 6 o'clock UK time, 7 o'clock Central European time. So we'll get started. And so first of all, on behalf of all the team at D.O.R.C, thank you very much for making the time to join this webinar this evening on the topic of secondary IOL fixation. I'm going to hand over in a second to our speakers. Just before we do get started, just to remind you all that anyone joining is automatically joining with your microphone muted, your camera off. So therefore, we encourage you to use the chat for any communication you have, either any technical issues or equally and more importantly, any questions you have to the speakers. And we'd really like to encourage you to ask questions during the session, during the presentation. Each of the presenters is allowing around 5 to 10 minutes for questions, and we'll be discussing all of the questions that you raise during this session. And we really encourage you to ask questions to all of the speakers. So without further ado, I'll briefly introduce and then hand over to our speakers. So we're really delighted to have Stratos Gotzaridis joining us this evening to talk about the Carlevale IOL, Steve and Lash to talk around the adapted Yamane technique, and Louisa Wickham talking about the 4-point akreos technique. And moderating all of that and introducing tonight's session is David Steele. So without further ado, I'd like to hand over to David, and you can take it from there. Thank you very much.
Great. Well, thank you very much, James. Let me just share let me get my screen on the right slide. Go back one. Great. Thank you very much, James. And I'm really looking forward to tonight, a night of surgical technique discussion, which is what we all like. So a short introductory talk. Of course, not so long ago, it wasn't that long ago since we didn't really have very many choices. And you know, the open loop ACIOL was an innovation in its time. And many of us used that for many years, and many of us still use it occasionally in some cases. It gives relatively few problems as compared to closed loop IOLs, which are a thing of the past now. The problem with open loop ACIOLs is that there's relatively few cases where IOL fixation without capsular support are suitable for ACIOLs. They're still suitable for the cases debatably with the things I've listed on the left, although many of us rarely use them at all now, but they're still used by some, but several requirements for their optimum use. And they have a number of problems, one of which, of course, is there's no set size for an ACIOL. They come in different sizes, but mobility of ACIOLs is common, and you know, they can be associated with endothelial problems, and the eyes that we implant secondary IOLs in often have predisposing endothelial problems in any case. So people started looking around for alternatives, and of course, IOLs were sutured with Prolene in the past, but because then we realized that conventionally sutured Prolene lenses with scleral pockets had their own problems with suture breakages and exposure. So people looked around for alternatives to these with Hoffman pockets, which are still, of course, very useful techniques to be aware of. And ZZ techniques are a personal favorite of mine for suturing, which avoid knots and avoid knot breakage problems and avoid suture and sticking up problems. But of course, you can't use ZZ for everything. So iris clip lenses were introduced and have been still used very successfully by many people. Initially introduced by clipping to the front of the iris. And then, of course, they can be clipped behind the iris with good cosmetic appearance. But I went through a phase of using anterior clipped lenses, then posterior clipping. And then, you know, it started noticing occasional problems with iris chafing, with dislocation, causing corneal edema. And although they can be reclipped, they still you still worry about the future endothelial problems, and even posterior clipped ones can get problems with irises. And then of course you worry about the rate of cystoid macular edema if you've got so much iris irritation. And of course, I'm not saying iris clip lenses are associated with higher incidence of cystoid, but what drove my move away from these was trying to get something better, basically. So there's a number of scleral fixated IOL options, and of course led by Gabor Skariov, who developed a scleral tunnel technique, which many of us used for many years, which was the sort of original leader behind this technique, and still used by many people because it has got some advantages. But there's 3 techniques being introduced recently that many of us are now adopting. So a Gore-Tex sutured technique, classically initially with the akreos or IOL, Yamane, a style scleral tunnel fixation, which is a very interesting technique, and the Carlevale IOL, which is specifically designed for scleral fixation. Sorry, I put some pictures of these in, which I forgot to load. And interestingly, last time we did this, an evening of IOL techniques, we kind of asked the audience what's their preferred technique, and you'll see that there's still a lot of people prefer iris claw techniques, and because it's a good technique. But a lot of people are adopting Yamane, adapted Yamane, Carlevale, and sutured akreoses. Some people are still using scarios techniques, and some people, as I've said, are still using ACU IOLs for very selected cases. But you can see that we've decided tonight to concentrate on Yamane, Carlevale, and sutured akreos because they're being widely adopted. And when a technique is newly adopted, people like to know the technique, the precise technique. And when you introduce IOLs, there's several things you think about. You think about, how long will the IOL last for? We think about how easy is it to implant. In other words, what's the speed of implantation, and can we consistently center IOLs correctly? But there's another number of other considerations. What's the incidence of cystoid? How does it compare to other techniques? How much endothelial trauma do we get from the IOL when we put it in? Is it associated with tilt? Is it associated with iris irritation? Particularly relevant for the Yamane, of course. What's the risk of suture or haptic exposure? Again, relevant to all the techniques we're going to talk about tonight. What's the refractive predictability? Something we need to pay attention to, because we need to aim for at least for good refractive outcomes in these cases, even if they aren't always achievable because of poor visual potential and so on. You'll notice that I haven't really mentioned retinal detachment, because many of the people doing these techniques are doing them with a vitrectomy. And my experience has been that the incidence of retinal detachment, if you do these techniques with vitrectomy, with a full vitrectomy, is actually very, very low. And it'll be interesting to get the panel's discussion on that. But we still need to think about things like a pacification with gas or air, with the akreos in particular, and no doubt Louisa will mention that, and displacement of IOLs with air. For example, a common scenario is somebody who might need an endothelial graft, and what's the best secondary IOL technique to allow a bubbling technique for an endothelial transplant, and we might discuss that in our talks. So we've got 3 great speakers, I got these pictures, and they may or may not be pleased with the pictures I managed to find on the internet, all looking very glamorous and assured. And we're going to be talking about micro technique. I'm sure Louisa and Stratos will talk about micro technique, and they'll probably also talk about nano technique. But I suspect it's only Steve who's going to be speaking about pico technique, because technique is the most important part of these IOLs, getting consistent result with attention to detail. So I think Louisa's going to go first, and before I hand over to Louisa might be either interested or appalled to know that when I search for a picture of Louisa, I have got some other ones which I couldn't have shown because they're usually on nights out and so on. But when I searched for a picture of Louisa Wickham, consultant ophthalmologist, I came up with all these pictures. Now, many of you in the audience may recognize Louisa on the top row and other eminent ophthalmologists, but of course, for some reason, my picture comes up when you search for Louisa Wickham, which must say something about my ambition, Louisa. But in any case, I'm going to hand over to Louisa now, and look forward to your talk, Louisa. Thank you. I'm going to stop sharing.
Thanks very much. Let me just share my screen.
I should also say there was a question already, but I'm going to hold it till we have Louisa's talk.
Right. I'm hoping that is sharing. Let me just turn it on to presenter mode so that we can get that on there. Right, is that on full screen now for everybody? Yes, I can see some thumbs up. Good. Okay. So thank you very much, David. And I think another thing that would be quite interesting to look at is whether or not people just use one technique, because that's what I think is also quite interesting with this. Because for me, I think you rightly pointed out at the start that all of these techniques will have an upside and a downside, and all of these techniques will potentially suit one patient population more than others. So what I'm going to try and do is first say, well, who would I really use the akreos technique with? Well, obviously no capsular support. You need enough mobile conjunctiva to actually do a peritomy. So that's who you definitely need to assess that before you put them in. Certainly younger patients, I like this technique with, and of course, if you're not going to do an ACI well, then these patients sit with this. Patients who are aniridic, I think, again, so clearly you can't use your artisan clip with an aniridic patient, or if they have significant iris trauma. And I suppose for me now, probably one of the most common indications of when I'm using this is patients who are due to have corneal grafting surgery, either DMEC, DSEC, or PK. Many of my corneal surgeon colleagues are referring me these patients because actually this technique is very forgiving if the view into the vitreous and into the posterior cavity is quite poor. When should you really not use this technique? Well, I think if you've got large areas of scleral thinning, I think anything which relies on a suture that is going through the sclera, I think you need to think very carefully about. I would also say scleritis is potentially one that you want to be careful of. I have had with Gore-Tex one patient who's had an area of localized scleritis. And so I do think we just need to be mindful of that. And sort of, as I kind of said, if you've got significant conjunctival scarring or thinning, you really can't use this technique because the covering of the Gore-Tex is essential to make sure that you don't get inflammation. So what are the key steps? I think for me, putting in secondary IOLs is definitely the preserve of people who are very obsessive about detail, because the way in which the success from the refractive perspective is achieved is right at the very start and really being meticulous about how and where you put your ports. So here we have, I always use a Mendes ring, and I use a needle just to score the corneal surface so that I have a very nice thin line to use as my reference point. What happens, however, is if you don't dry on the cornea and you score and then you use a marker, you can get quite a smudge. And so here you'll see this come here. You see, you get a smudge like that, you don't know where you're at. So make sure you dry your cornea so that you get a really nice crisp line that you can use as your reference point. Then the next point to say is your peritomy. Again, you really need to make sure you take time here. Ensure that you get right under subtenons, that you get a nice clean scleral patch, and that also you're fairly generous, because what you don't want is to find that you traumatize the conjunctiva whilst you put in your ports, because again, it's that conjunctival realignment afterwards that is essential. And lastly, so here's a classic case of someone I've done who does have some corneal decompensation. You can see the view is quite poor. So here I spend an awful lot of time in port placement and being meticulous. And the way I do this is to have two calipers. So I set one caliper on 2.5 to 3 millimeters back from the limbus, and I set the other caliper at 5 millimeters. And this means that I'm not changing any measurements of my calipers whilst I'm doing the surgery. So here I have the second caliper, you can see going 2.5 back. And what I do is I use the first point to put my trocar in, and I'm holding here the eye still with the caliper so that I actually really know that I'm exactly where I want to be. And then I go back to where my mark is, that is 180 degrees across from the other. And once again, really making sure that I'm very comfortable that I'm in the right axis towards the other marker. And as I come out with the trocar, I just extend that a little bit so that when I use my 27 gauge forceps, that I can actually reach across and get through the sclera without having to put too much trauma. I use this only with 27 gauge, this technique now, because what you don't want is ports that leak. Your biggest fear here is hypotony in the early postoperative stage. So what I'm now going to show you is just a fairly sped up version of putting the whole lens in, and then I'm going to take some of those steps individually and talk you through them. Oh, sorry, let me just go through here. So it's important here to thread the suture from above to below and then from below to above, and that reduces the irritation or the likelihood of irritation of your suture on the iris. Once you've thread your lens, you pass the nasal side of your suture through your ports. And the reason to do the nasal side, it's the least forgiving, it's that the access is poorest, and so you therefore want to do that when it's easiest. This bit's going to look easy. This is where you fold the lens and you insert it. And the great thing about this is the lens is not going to go anywhere. You don't need to worry that this lens is going to go to the back of the eye. And then you take your next temporal port and pull them through. And you can see here that you can, it's very forgiving. There's no real very fine detailed manipulation. You're just grabbing a string of the Gore-Tex and pulling it through. Then once you've done that, reform your AC and you can take your ports out. Be careful here. You can see that the suture started moving. I have pulled out a suture before whilst taking the port out. And here you go. You suture, make sure that you've got a nice, well-centered lens. This second part of throwing the second knot on the suture is really important. We'll go over that in a bit more detail in a minute. You tie the other side. And then it's really important at this stage to do your corneal suture before you try and rotate your knots. Okay, so I'm going to take a couple of these sections in first. So when you saw that section, it looked really, really easy to fold the lens. I can tell you now that it isn't sometimes so easy. So the lens is very malleable. So the important thing here is that you put your iris repositor across the whole length of the lens as much as you can, and you push up with the iris repositor and down with your lens folder. And you can see here how it can be a bit slippy. If you open your lens folder too wide, it will slip out. And if you don't do it wide enough, you can't remove your iris repositor. So this is the bit where people often start using quite interesting language. So you need to get it nice, straight, and then you can go through into your corneal section. Make your corneal section generous enough to be able to put your lens in easily. Again, sometimes we get to the point here, you see it really stiff, really stiff. Now we've finally folded the lens and we're now really irritated that you can't get it into the eye. So make sure that you make your corneal section easy enough to get through, particularly when you're starting, make it slightly more generous. Okay, here is again another folding of the lens. Let me just pause that one so we don't have to. This is another common mistake, which is you can see the flaring of the lens here. This is because we've not put the iris repositor down the full length of the lens. And here again, they're trying to kid themselves that actually what they can really do is introduce this lens into this corneal section, because they really don't want to have to fold it again. You can see here we go, try and push, 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 push to try desperately to get that lens in. So what I would say is don't try, and if it's flared at the end, just accept that you just need to refold it. Okay, so once you've folded it, ensure that all your sutures are nicely laid out. So this is again about being meticulous and about being slightly obsessive about this. So here we go, the lens has gone in, but we didn't make sure that the suture material was nicely laid out. And now you've got this awful mess of a cat's cradle of suture. You don't know what's above, what's below, where the lens should be. And again, when this first happened to me, I thought, oh, this will be fine. All I need to do is to pull on this suture, pull on that suture, it'll all be good. It actually was not. You had to take it out again. And the reason this happened was because I deviated away from what I'd always done before, which was to do the nasal side, and decided to put one on the nasal, on the temporal. It just didn't work. They got all caught up. So again, keeping it simple and tried and tested. Try and make sure you do the same thing each time. So here we've got the lens in place, and what we're doing here is trying to make sure that the centration is as good as possible. The thing you need to be aware of with the akreos lens is it's very malleable. So if you pull too tightly on these sutures, then the lens will curve and you'll get an astigmatism across the lens. So you want to make sure that you do a bit of a push me, pull you release on one side and you pull across. Just remember at this stage that you're going to have much more forgiving refractively if you've got a slightly off-center lens than if you've got a curved or tilted lens. So even if you get it slightly wrong, you're better to accept a slightly temporal or nasal decentration than to try and tie your suture too tight to overcorrect it, which is what the temptation is to do. Here you can see that the second knot is being put on. The trick here is just to really try and make sure that you move the suture as little as possible whilst you're putting on the second knot, so that you're not increasing the tension and you're not causing a movement of the lens. So constantly, whilst you're doing this, you're looking at the lens to make sure that you're not moving the lens at the same time as you're doing the knot. And that probably for me is one of the most difficult parts of this technique, is to really be very gentle with that suture. And finally, here you can see a case where that wasn't the case. So someone here has really tightened that, and you can see how the lens is, you've got this sort of V shape. So if you've got this V shape, you've tightened the suture too much. And you can see here that we've had to adjust this because of the astigmatism and cut it. And as soon as you cut it, you'll begin to see this lens begins to open up again, because it's been over tightened and you get curvature. So the other thing is to try and keep your manipulation to a minimum. So again, what we have here is the suture's tied, and we're now trying to bury the knot. Burying of the knot is an absolutely essential part of this technique. Never kid yourself that you can leave a knot on the scleral surface and it will be okay. It just won't. You'll get a nasty granuloma. So the thing to ensure that this is easier is to make sure that you have sutured your cornea. You can put up the internal pressure using your infusion line. I sometimes put it up to 40, 45 if I'm having an issue. I grab the mainstay of the knot rather than the suture material, and I try and be as perpendicular as I can as I go in to make sure that I'm aligned correctly. Sometimes, because of the delicate nature of a 27 gauge forceps, you may want to increase the strength of it by holding it close to the end with your Moorfields forceps, and that helps rigidity. Here, this is the point to be careful of. Gore-Tex is very strong, but also quite delicate. And you can see here how if you grip the Gore-Tex, you cause kind of clamping of the suture material. Now, I've never seen it break, but I'm always fearful that if you are manipulating the suture too much, that this might be a point of weakness at a later time. So finally, just to say about once you have done this, so this is someone who thought it would be fine to leave the suture on the top, and this is just to remind me again to tell you not to do that, and they've sewed it up. I can tell you we had to go back to this patient and redo the sutures and bury the knot because they ended up with 2 suture granulomas. Let me see if I get the last one. David referred to the fact about opacification of lenses. Now, I've only had actually one opacification in it all the time I've done it, and that was in a lady who had a history of retinal detachment, who then got a detachment following her akreos lens insertion. And we ended up having to use C3F8. And because we ended up using C3F8, she had a long period of time where the gas bubble was opposed to her lens, and she did get opacification, and so we took it out. And because we knew she had a risk of further detachment along, we use this lens here, which is a micropure lens, and it is hydrophobic, and therefore it has not had the incidence or problems with opacification. And so if I have a patient who I think there is a high likelihood of us using any kind of long-acting gas, I now put these in instead, and they've been very stable and have worked very well. So if you have that concern, you might want to consider this as an option. And finally, this is just a bit of fun, really. This is just showing you how you can actually rethread one of these in the eye if you need to. It, again, is a bit of fun if you've pulled it through. So if you do pull it through, which has happened to me at the final point, it is possible to go back into the eye, rethread it in the eye and pull the suture materials out, because you've got nice wide eyelets and good ports to take it through. And that's it for now, and I'm very happy to answer some questions. I can't see the chat on the side, I'm afraid, James, but I'm sure you'll be able to pass those through. Should I stop sharing? That might be easier at this point.
Great, thank you very much, Louise. That was incredibly clear and precise, and some great tips there. I love the 2 caliper tip, because that's a great one, and the loose suture technique, so tying very loosely, because that's something I've noticed as well. And just before, there's several questions in the chat, so I'll ask them rather than asking me ones. But one quick thing: what was the alternative IOL you mentioned for which doesn't, you're less concerned about opacification issues? What was that called?
It's called micropure. It's a micropure lens. They do a number of different versions, but that's the one I've used.
But I guess you could adapt this technique to use a range of IOLs, even conventional optic IOLs. Have you done that or not? Or?
I haven't. I mean, I've seen videos of people create holes and thread through and do all sorts of that. And I think I've even seen people use the SN60, for example, and sort of thread through suture material through the lens. But I haven't. Must admit, I haven't done that.
Yeah. So there's one question which is very relevant. It says, from Ahmed Robbie, does burying the knot in the trocar reduce the risk of hypotony? So you made a point of saying you pushed it towards the trocar one, didn't you?
Yeah. So the trocar one is the scleral fibers have just been deviated for longer, and therefore it's just more forgiving at that time. But once you've pushed it through, if you press on the scleral port, just like you would do as you remove your trocar, you'll find it actually seals quite well. There are occasions, so if you are worried about some leakage, so I watched it, you could actually do a bit of wound hydration, just as you might do after corneal surgery around it, and that also seals it up. And then actually I found what I tend to do is I cover it up and then I take the infusion line out and I really spend some time making sure that the pressure at the end of the operation is at the upper end of normal, so that you feel confident that you've got some good internal pressure to keep those wounds shut. If you leave the eye hypotenuse at the end of the operation, then you will end up having more leakage and a hypotony becomes an issue. So for this, you want to, again, be really meticulous. Make sure your corneal wound is well sutured. Corneal suturing is really important for this. I've seen one case where someone just put a single suture in and then it was leaking on either side. And because they had hypotony at the end of the operation, there wasn't enough internal pressure to seal that wound. So that's why make sure your pressure is good at the end of the operation, so those wounds are self-sealing before you stop. That's
a great tip, and that applies with vitrectomies, of course, as well. But relevant, similar to this, is the question is, how do you ever need to suture your sclerostomy? So I've seen that before myself, but you haven't had to do that.
No, I mean, as I said, I use 27 gauge for this.
Yes.
When I use 23 gauge, yeah, I was more worried about this. I think my concern when you suture is that you might go through the suture that you've just rotated as you do it, and so there's a risk of doing that. But I have found with 27 gauge, again, with a good pressure and a bit of pressure on the wound edge, I've not had that problem.
Okay, right. Now this is a question common to possibly all three talks, but is what do you do if you get if you do get resistant cystoid, let's say, so non-responsive to drops? It does an akreos because it covers the pupil so well. Could you put an Orsidex implant in and not expect it to come with the AC, or is that not the case? What's your experience of that? First of all, Louisa, then we'll get Stephen Stratos involved in that question as well.
You know what? I haven't actually had to put an Orsidex in yet for one of these. So far, everybody I've done this to has responded. I mean, I've had one or two where they've had a bit of a CMO that's lasted maybe about 4 months, but they've all responded so far to topical treatment. One thing I would say, and is an area of interest for me, is what we do with the capsule. So, for example, if I have residual capsule in these cases, I don't remove it and I leave the capsule, whatever there is, because I feel that we often think that we do it for neatness, don't we? We think, oh, I'll just take the capsule out because it, looks neater. But I'm sure the capsule, as everything in nature, has a function. And for me, I just wonder about whether or not it helps keep the iris in a better thing. Because there's some really lovely ultrasounds that show in patients who are aphakic without capsule, the movement and the retropulsion of the iris. And so for me, what I do is try and do that. And the 2.5 to 3 setting back, I think, has also helped. So far, fingers crossed, I've not had a case of refractive CMO with these.
That's a really great thing. So Stephen Stratos, the capsule is really interesting because I've noticed that as well. Do you leave capsule?
I leave it. I just leave as much as I can. And what's quite nice about that is when you put the lens in, you can see it's going in the bag with the Yamane technique. So it's quite nice. In terms of cystoid, I smile because I shouldn't smile really because it's terrible. I put 2 Orsidex in refractive CMO, one in an NHS patient, one in a private patient, exactly the same week. Had they been split by any number of weeks, only one of them would have ended up with a corneal graft. As a result, both of them ended up with corneal grafts. The Orsidex just makes its way to the front and the cornea just goes. And I think even if I don't know, if you watch it come into the AC and take it out, maybe you'll be okay. But the toxic effect is just terrible. So for refractive, what I tend to do, I'll talk in my talk, but I don't do PIs on everyone. I've got 250 cases. CMO is somewhere 5-10%. but it does feel more because they're often refractory. So stage 1 is max dexamacular. After that is an orbital floor with a PI, a YAG PI. And so far that's worked.
So so Stratos, have you got any experience of suturing things like ILUVIEN in these kind of cases? Because I've always avoided, as Steve just alluded to, using Orcidex. Have you tried the sutured ILUVIEN technique or anything similar?
No, I haven't tried that. I don't know. No experience.
I mean, what would so would you agree that you wouldn't put a free floating Orcidex in any sort of secondary, IOL without capsular support technique, or would you?
Well, I would definitely avoid to do that because I saw some kind of toxic reaction to the endothelium with devastating results. So I would avoid to do that.
Yeah, they seem to find their way, and I've always avoided it on the basis I've seen other people where they haven't got away with it. So it's a problem, isn't it? Do you think that collective experience? Do you think that? So first of all, how many of the three of you have you done artisan type techniques and then did it and then stopped doing it? Is it so? Just Steve.
I must admit,
Zero. I have done
yeah,
0%.
Yeah, it's just interesting, isn't it? It just feels that it's a mobile structure, and that kind of attaching something to a mobile structure, I've always kind of felt uncomfortable about. So I must admit, I've not done them.
Plus the chronic irritation of the iris doesn't feel good.
Okay, right, good. So it's interesting.
The last
Steve.
artisan I used, I had to do it because I could not find a powerful enough lens in any other format that I currently use. So I used an artisan, and even that I had to anterior bolt. I wanted to posterior bolt it, and I couldn't because I couldn't get the power up. And she's already, the iris is moth-eaten, and it's So I've gone off it.
One interesting thing is which brings in Eddie Doyle's comment is that so with megalocornea, or so with big anterior segments, very high myopes, Yamanes are not so good because they have to stretch them too much. Akreos is obviously something you can do, and that's what I would do now. But I did when I was doing artisans, I put a couple of artisans in megalocornea cases, but they've got atrophic irises, and so the picture I showed Eddie was with the progressive iris atrophy was one of my megalocornea cases where they got progressive iris atrophy, and it's a known effect. So I think for me, an akreos would be the technique, or a Carlevale, which Stratos will convince us about shortly. But I think we'll move on if that's okay. So that was sorry, Louisa, one more comment.
Just gonna say, Mahmoud, you just asked about an exposed Gore-Tex knot. I would just say you definitely have to go in, cut it, and either rethread it or move it. You can't leave them. They never settle, and they can then get a localized thinning underneath. So yeah, you need to go back in and sort them out, unfortunately.
Great. Sorry, I missed that one, Louisa. Well spotted. And well, actually, because your second question about scleral morphology is relevant to Steve's talk, and Steve's got his talk up. So what we'll do is we'll do Steve's talk, and then we'll have some more questions after that. Thank you very much, Steve. And Louisa. Sorry, thank you, Louisa.
Right, I'm off mute, so hopefully you can see and hear me now. Thanks to D.O.R.C for the invite, and I'm very pleased to try and present my experience with the modified Yamane. I think that 10 minutes is pushing it to really get into the grips of it, but I'm going to go through my technique and why I modified, and it's really evolved 4 waves of modification. I'm actually going to show you an unedited case and talk you through that, and then I'm going to show you some curveballs at the end. So I'm going to assume most people have at least fiddled with this technique, otherwise yeah, it'd be tricky. So why did I modify? Well, the first thing I want to say is if you can get the kit Yamane uses and do it his way, it's better, it's slicker. I've only changed it because I couldn't get hold of his kit, notably the 30 gauge needle. I started doing this back in 2017. My first case was an absolute dream, 30 minutes, 4 fellows watching me. They must have thought I was absolutely amazing. Went perfectly well. They left. My second case I abandoned after 2 hours and gave up. So 30 gauge needles do not work unless you get the wide bore. So I went over to 27 gauge, and I used haptics together on 27, as does Yamane. But I started to get some slippage, and as a VR surgeon, you're often grabbing them and pulling them. And then the other thing I would say is, I spent long time chatting with David Steele, and I've also chatted to Gabor Sharath about his technique. So it's important when you're learning a technique just to chat with people who are good and enthusiastic. And David was burning as you go, so I thought I'll give that a whirl. So burning as you go is great, except the angles change. And the second haptic with the Yamane is quite a technical challenge, and I found a lot of people had given up because of that challenge. So I reversed the order. So I then have the trailing haptic first. Now, if you combine the trailing haptic with the burn as you go, the angles become almost impossible. So over 90 degrees, and I'll show you this on the slides. And there is a very high risk of kink because I use the lenses we have in stock, which are ZA9003s and AR40s. They're PMMA haptics. Again, if you can get hold of Zeiss, Lucia's, they're an unpronounceable haptic, which I've written later in the talk, but the unpronounceable haptic is much more forgiving. So it bends and flexes very nicely. And so I introduced the second bend on the second needle, which I think is the most critical modification I've done, and that makes it straightforward. So wave 1 was changed to 27 gauge and an AC maintainer. Now this is the very first case I did. So it was a drop lens, 30 minutes, came out really well, but that isn't going up the haptic. But there's something there about micro technique, which some of you may or may not spot, but I'm going to point that out later. 27 gauge, usually easy. Of course, these 27 gauge needles are manufactured mass, and the haptics may not be exactly the same size. So sometimes you get a tight fit, sometimes you get a loose fit. Sorry about this next video with the AC looking like that, but another thing I find when I'm trying something new is I focus on what I'm doing and forget that the eye is collapsing. I'm just waiting for the big black shadow to appear there, which never did, thankfully. So an AC maintainer or a posterior infusion, if you're doing VR work, it makes it very easy and very nice. So give yourself a following wind whenever you can. So the wave 2 was the haptic slip. So this is where I transition to burn as you go. So with normal Yamane, you just have the needles, nothing on them, and you let go of one and fix the other one. Then you grab both of them and pull them out. So you see there that both needles came out quite nicely, leaving the haptics there. Mostly what I found is one would get stuck, and then you'd be in this awful situation where you didn't want to pull too hard to pull the first one out. So I started to do burn as you go. Now, this case was a horrendous case. This guy thanked me so much for my 2 hours of effort to get the lens in place. I got chemosis, bleeding, needed a Malugan ring. But what happened there is I pulled them both out, but the haptic has gone under chemotic conjunctiva. And because there's been a lot of fiddling on a 27 gauge needle through the sclera, that wound is now a bit open. And so it just slipped back and that fell backwards. So the nice thing about burn as you go is in a drop lens situation. So this was a drop lens, which I refixated. You can obviously go down and grab it. Sorry about my voice there. And then feed it in and then pull it out. And so that's quite nice if you're dealing with lenses that have dropped that you're going to recycle. If you're going to burn as you go, you need to get a good burn. So here the burn was just too short, and then you're in trouble with not getting a decent bulb on the haptic and it slipping down. So wave 3 was the reverse order of enclavation. So here's this is again my very first case. I'm blessed with beginner's luck, which is a curse sometimes. So the aim here is to use one hand, the needle, to push the lens back. Remember, the other haptic has a needle on it, which is just flopping around in the breeze. So I'm always a little bit anxious about where the end of that's going. So I'm pushing, and this is unedited. And talk about a following wind here. This just slips nicely straight into the bevel, except it doesn't actually go up the bevel, it just wedges in it. So, and then if you push, it just kinks a little bit, because they don't fit. So number one message is don't use 30 gauge needles, it doesn't fit. So with the second, the trailing haptic first, you grab it outside the eye and push it through. I wouldn't do that again, as in what I did there, because the haptic is too long and you're in danger of kinking the haptic if you have that haptic too long. So instead of Yamane's first haptic, I'm now using the trailing haptic outside the eye first. So if you combine all of those things, you end up with this 90-degree angle. Can you see where I'm holding there, the needle? It's pretty much at 90 degrees. And then that makes it very easy to kink. So you have to take real care there. Now, if you have a look here, this was the first video I showed you, the bevel is pointing downwards and away. So that's a micro technique issue. You've got to get the bevel facing up towards the limbus so that it naturally wants to accept the haptic. There, the haptic is bouncing off of it, partly because the bevel is facing the wrong way. Double bend, I think, has made the most difference to me. So what I do is I rehearse it by laying the needle over the eye, twisting so that the bevel faces the limbus, and then I bend it. And then I get the second needle again, I rotate it so that the bevel faces towards the limbus, then I bend it, and then I grab it a second time about 2 to 2.5 millimeters from the end, and then just bend that up. So I use my markers, which are at 2.5, and bend it. So here's an unedited example. If you can, sorry, I've got my voiceover, so. So you don't want the haptic to go behind the iris. Can you hear my voiceover here, by the way, David? No, you can't hear a voiceover. Okay, I'll talk through it. So you don't want to get that iris behind the haptic behind the iris. Now you're going to use your first needle very, very flat on the sclera. I'm 2.5 millimeters back. And you're going to push that through. And now this is at about, I don't know, 150 cases. And what about to happen never happened before, but it happened on this case, just to show. So I grabbed the haptic about 2 millimeters or so from the end. And what I managed to do here is get an annoying bubble. So it just makes my view a bit tricky. Also, having had some experience with Malugan rings now in the last 50, which I'll talk to you about, I've dislocated the Malugan and ended up threading the haptic through the Malugan, which is an absolute fiddle fest to get that undone. So you want to push gently. You don't want to push hard because you don't want to kink. You're always thinking about kink. Then you're going to rotate the needle out and swing it round just as the way it went in. And this can be very difficult on a left eye. So if you're going to do your first one, do it on a right eye. And then I grab it, even though it's not going to pass back, I can then pass that off and get the hot rod, which is a Bobby handheld cautery, approach it from the end and just burn it. And just a little burn, don't burn it too much, because if you have the haptics too short, the same as if you put it in a highly myopic eye, it can look great at the end and you see them post-op and the whole lens is twisted because it's actually pulled, sort of pulled on its edges. So look at the angle on the first haptic, it's digging into the iris. So we just make sure you haven't skewered the iris. And then we're going to use the second needle. So I've got 2 paracentesis. I've got one at the top and one at 45 degrees to the right. So I don't do the 2 paracentesis Yamane does. You're not going blind, I'm about to refocus. Now, the important thing here is you keep this flat, but when you rotate the needle into the eye, you have to come over yourself, as it were. So push the bevel backwards. Otherwise, because it's double bent, it'll scrape across the iris. So you need to come sort of push it forward and backwards. And then you're going in. So I use the D.O.R.C serrated end grippers because they're nice and long, and I can just grab the end there. And again, about 3 millimeters from the end. Now, this is the important bit. You can't push yet. You engage. You then flatten the needle, and then you push. If you push while it's not in line, you'll kink it. And again, come out very slowly. And what I'm a little bit scared of here is pulling the other haptic out. So I grab it and I burn it, and then that's done. So curveballs. It's, there you go, there's the unpronounceable, polyvinylidene fluoride. So great, Zeiss Lucias are great, and if we had them on stock, I'd use them. But what I like about this technique is that we have ZA9003s and AR40s in the cupboard, so there's no ordering, no issue. So, in fact, the fellow who did this, I know, is watching, so he won't mind me talking about this. Here you're going to see information overload. What I'm trying to say to him, and this is his first case, he did very well and the patient did very well. I'm trying to say to him, get the needle straight and don't push. But you know how it is. You just can't seem to manage that. So he's pushing. Can you see the haptic? And the left hand is moving towards, so we're pushing again. So I'm just saying, I think amazingly calmly, stop pushing. Forget your left hand, go straight. So he still can't quite manage to get the left hand straight. See, so we're pushing again, and and then he manages to get it. So it is a fiddle, but you mustn't push until you're in line. Insertion of the lens. So let's go through the curveballs at every stage. So the first bit is the haptic can drop behind the iris. You should definitely try and retrieve that, especially if you're an anterior segment surgeon, because once one haptic's behind the iris, it's only a matter of time before the second can go behind the iris. And two haptics behind the iris mean finish and call the VR surgeon. So especially if you're an anterior segment surgeon, please keep it in the anterior segment. So reposition it. What I said about the external grasp of the trailing haptic, don't grasp it too long, otherwise you'll kink it. So about 2 to 3 millimeters, and you want to diagonally push across the wound to get it into the eye. And then if the haptic pops out, so you try and feed it up, and sometimes it just pops out, you've got 3 options. Well, one is you can rehearse outside the eye to see if it fits, which I've stopped doing now, but you can redial it in the eye, which means your right hand with the needle remains in the eye. You use that needle to rotate the lens with the end grippers open, trying to rotate the haptic back into the jaws and then enclavate. You can make another paracentesis 90 degrees so that you're at 90 degrees to the haptic to refixate it, but that can be tricky, especially with facial features. Or you can externalize the haptic and start again, but again, you must be very careful not to kink. So imagine you're an anterior segment surgeon. This is an aphakic eye, an aniridic eye I did, and I had the clever idea of using the D.O.R.C to support the haptic, which you can see worked not at all. But just imagine how you're feeling at this point now. But amazingly, like they do, it's just hanging on by the skin of its teeth. Here's one where the haptic slips out. So I've gripped, I've got a good amount of haptic there, just struggling to get it in. And as it goes in, it just, I think it's in, I've pushed and then it pops out. Now there's not enough haptic there to refixate it, so I had to redial that one. Curveballs number 2, the lens going vertical, and this is exclusively left eye, as I've now come to understand, and it's due to the nose steep angle of rotation. As you withdraw, beware, because the other haptic is rotating forward and it can skewer the iris. So just be wary of that. And then sometimes, especially in the left eye, again, when you've got steep nasal features, you can get sudden movement as you come out of the eye. So I'm going to show you these 2 cock-ups. So here's a lens going vertical. So that's going in nicely there. And I think there's 2 reasons. I think partly because the bevel is facing up and out. As I come out, I rotate it round, which can twist the lens. But look at this lens. It's got caught, the haptic's caught, and it's going vertical. Now this one ended up with that iris being skewered, and the iris went up to the hilt of the haptic optic junction. And try as I might, I had to cut it and remove it. So beware of the lens going vertical. And then this is another one where I'm literally pulling. I know that I knew that I was a very odd angle. And I was telling the fellows that we have to be very careful here, and it's still kinked. What I did here was just did a slightly longer burn and burnt it back down towards the kink, and then that was absolutely fine, but I got away with that. Curveballs 3, so the iris skewer. So if you do get the haptic through the iris, I would use 2 instruments, 2 grippers, just to hand and slowly retrieve it, because there's not much space to pull the haptic out. If the haptic's sitting in the angle, just take great care, because you can grasp the iris root and touch the endothelium. If the haptic is behind the iris, I'd just reposition it with care, be wary of kinks. And Manugan ring, I've had 0 issues for 150 cases, and then I've had 3 now, which have been absolute nightmares, where I've threaded the haptic through the Manugan ring, and you have to cut it in 3 places to get it out, in my experience. It's a lot of gymnastics. Curveballs number 4, the second haptic, when you put it in, the kink, which you saw my fellow attempting not to do. So the double bend, and then remember to engage and then straighten. If you externalize and it gets stuck, you can pull the first haptic out. So grasp as soon as you see the blue, but just take care. And you can externalize, re-externalize it again. And remove the Manugan ring, it has a muscle memory to it. And I had one case that went brilliantly. And as I came out and pulled the Manugan ring, it suddenly flicked, went backwards and dislocated the lens. So here's the first haptic being pulled out. I think what I've probably done is not done a good enough bulb on the first, and I've threaded too much of the haptic up the second. So as I pull, you can see that lens is now going vertically backwards. Not a great idea. But if it does happen, you can just externalize the haptic. What I usually do is actually use the keratome, place the bulb on the keratome and come out with the keratome and the bulb at the same time. If this does happen, you can cut that bulb and it will go up the needle and you can reburn it again. So other intraoperative complications, I've had some retinal tears. I don't mind a couple, and I would just treat those and then go to air, and it's usually stable. I've had a few where there have been multiple tears and I've just stopped. I've treated those. I've gassed the eye and I've come back at a second time. I've had a retinal detachment during surgery. So I just, again, tend to treat it and place the lens as a second procedure. And I had one high myope with a suprachoroidal hemorrhage. Again, I stopped, came back as a second procedure. He did well. In terms of my post-op regime, it's steroid, non-steroid and antibiotic. I've had no issues with pressure so far. CMO is the big issue for me. I've got a team that are just trying to audit my 250 cases now. I think it's somewhere around 5 to 10%, but it often feels worse. Do not use Ozurdex. And as I said in the introduction, maxillosinacid after a month, then a slow tail. If it's not settling, PI and orbital floor. If you get iris capture, what you need to do is, unlike normal iris capture, where you would dilate the patient, lay them on their back for a couple of hours, what I do is I give them pilocarpine straight away in clinic. I get a 30 gauge needle and push it back, and I then can do a PI in clinic. And like Louisa, I leave as much debris as possible behind that I can. My main issue at the moment is I'm always operating at the top. So I always get SIL, which sometimes is great. They get a multifocal outcome and sometimes it's not so good. I'm wondering about on-axis surgery. I just don't know how the lens is going to sit at various axes, but that's on my mind at the moment. Vitreous hemorrhage in less than 3%, which clears on its own. I've had late slip in a Marfan's ×1. I've done another Marfan's, which went well. This Marfan's was a nightmare. I had a funny looking eye. You know, the sort of eye that is funny looking and probably not good for this technique. And then I had a late slip because I hadn't done proper bulbs, my error at the start. Learning curve, I would say the first 50, you build the list around the case. You know, you think about it. 50 to 150, you concentrate on the case and build it around the technique. Over 150, still surprises. And over 200, you'll have to speak to my fellows, really. I think it looks mainly very slick, but I do occasionally make it look extremely difficult. And in the last 50, as I say, I've had a vertical lens, a skewer, slippage, and I've had 3 Malugan ring incidents. And then one, I had a severe head tremor. And what I did is I just didn't sit back and think, you know, is this a sensible technique? And I think in that situation, an AC lens would have been a much better option. Thank you.
Fantastic, Steve. That's just a great example of experiential learning.
Yeah.
And fantastic. There's so many top tips in there. It's difficult to know where to start. But the one thing I just wanted to pick up, was particularly interested in it. Well, two things actually. Well, first of all, I always use an AC infusion. Why don't you use an AC infusion? Is that
so I do. If I've got posterior setup, I use the posterior infusion. Initially, when I started, I felt like some AC seemed to collapse with the posterior infusion and some didn't. I now think that was me overthinking it. So as long as I got an infusion, I'm fine. But if I don't, I have an AC maintainer.
Right. Okay.
But so just a tip: if you've got aniridia and think you can balance the haptic on the D.O.R.C, it doesn't work.
That's the other thing that came across very clearly was these eyes are not normal eyes. Every single eye you showed there, apart from 1 or 2, were very abnormal eyes. So
yeah,
very hard. And so when you're burning the haptics, so it's very difficult to be consistent. If you burn too much, of course, you shorten your haptics, and then it's too short. And of course, the shorter the haptic is, the more you have to stretch the lens, and that alters the lens position. So do you do that? I try to grab it a certain distance from the tip, which is about 1.5 millimeters for me, and I burn it. So I always burn 1.5 millimeters.
Okay.
But you basically it's probably because you've done so many, you eyeball it. But do you think?
No, I think that's a great tip. But what I do is I just burn it until I've got a knuckle, and that can be very short. I just want a knuckle.
You also I don't think you said this, but I know you do it. Basically, you have to make sure your haptics out of the water, don't you? You have to have it in dry air. So
I showed it's a bit quick, wasn't it? But yeah, the pour burn is if you're in the tear film, then you don't get a good burn. So yeah, you have to lift it out and away.
And again, one thing all my views on this. You demonstrated beautifully, Steve. But so avoiding tilt. So top tips for avoiding tilt.
I think measuring. So centration and measuring is important. So again, I used to use the Boris axis rule, and then I went somewhere where they didn't have one, so I use calipers now. But make sure the eye is pulled central. So the Purkinje images, the reflexes are central. Because if the eye is slightly tilted down, you'll center it wrong. Make sure it's 2.5 exactly measured either side. And then the most important thing is don't kink the haptic. If there's one thing I would say about this technique is don't kink the haptic, because then who knows where the lens is going to sit.
You also took great care, which to actually enter as your needle entered the sclera, to keep it parallel to limbus and also quite acutely tunneled, so that the longer your tunnel is, the less the risk of tilt is as well. I think that's
absolutely
so there's a question on the thing, which is relevant to potentially all techniques, but do you ever think that the sclera is going to be too thin, like for example high myopes?
Okay, great question. And I did this chat with Marfans. He was it's like everything. Once you've been through it once, you spot it. So the ports went in like knife through butter. That should have alerted me. The first haptic went in, and I pulled it out. Had a nice bulb on it and stuffed it out. Did the second one. First one came out. Put the second one in. He came back afterwards with the second one out again. So I took the lens out. He then detached. It's an absolute nightmare. The good news is he ended up 6'6" at the end of it all, but with no lens in his eye, which is probably. But yeah, he was a nightmare. So then I did another Marfans, but this time I checked how the ports were going through the eye, and I checked the sclera. I checked how it felt, and it all felt well, and it went fine. But I would say that's a curveball for anyone. I had the funny looking eye was another one where it was all a bit thin, and I think you do have to just look for clues.
Yeah, I've done quite a few Marfans. I think they're fine, but I completely agree. The two risk scenarios, which I think you mentioned as well, is so I used to reposition lenses. So if you had a drop 3-piece, I tried to reposition it. I thought that was great, but in actual fact, the haptics often tend to kink. And the other thing you mentioned is if you have multiple passages of the needle to the sclera, that's a kind of a feature of the lens dislocating, because the tunnel's too baggy, I guess.
So I've repositioned a few, but the other interesting thing is I've repositioned a few MA60s. Now the shape of their haptics is different, and that changes the angle. So you can find you're really struggling with the angles again.
Right. Okay. And so you made a point about, so there's a question about the lenses. I use MA50 Alcon MA50s, which have got a 6.5 haptic optic. What do you use, Steve, again? Because I think the question is what
ZA9003 and an AR40.
So who makes them? What are they?
As AMO.
And they're a 6mm optic.
And AMO Sensor and Technis.
So they're 6mm optic lenses but you think the haptics are more flexible on them? Is that what you?
No, the PMMA haptics will kink. So if I could have anything, I'd use the Zeiss Lucia 3-piece, because it's got lovely flexible haptics which don't kink. But we don't have them on stock. And one thing I love about this technique is I don't have to order anything; it's there.
Yeah. Okay. Great. So Louisa and Stratos, have you got any experience with this technique and anything you want to comment on?
I've done it with an MA60 before. The only thing that I've always found the Yamane technique is the putting the needle through the sclera, which is where I've always been a bit anxious. So one way I've done it in the past is to use the trocar and cite a trocar rather than cite a needle, and do the same idea but through the trocar, which can also work with a 27 gauge for this.
But then you have to when you grasp it with the forceps, you have to get the very tip of it to be able to pull it through with the forceps and the trocar.
So once you've got it, and you know that you've got it, as you're beginning to pull, you can slide the trocar up your forceps.
Right.
And you pull it out.
So you've only got to get it into the entrance, and then you can, okay, right, okay. And Stratos, was this a technique you did?
Well,
and then
I have tried a
on?
couple of times when the technique started to become familiar, but I have used probably the wrong IOL. I was using the Alcon's MA60, where Steve said that its haptics are not, yes. So I had difficulties to place the second haptic into the needle. And also, I feel a little bit scary to have a needle into the eye, trying to fish the second haptic just below the endothelium and above to the iris. I feel it a little bit risky and dangerous. So I stopped it and I went back to Agrawal's technique, which I'm going to present you some results that I have, which I found it much easier than the Yamane's.
No, we're really looking forward to your talk, Stratos. Steve, there's a question from the audience. There's one question about an alternative 3-piece IOL suture to the iris, but of course that's a different technique. But all techniques can work with experienced hands. But another technique, well, if you notice the lens is dislocated on the first day, it says inferiorly on the question. What would you do?
Well, it depends. So the lens I use is aspheric, so a bit of decentration isn't an issue. So I think I've replaced maybe a couple out of those 200, and they're usually in the initial cases. So I don't usually find it a problem, but you've raised an interesting other question there, which is a question we should all ask ourselves, which is how long is a learning curve? And you have to balance that with Louisa's point that you can't be a one-trick pony. So on one hand, I'm now feeling, you're best speaking to my fellows, but I would suggest that I have no increase in blood pressure or pulse rate if I have to do one on the spur. It's just comfortable for me to do now, but it's taken a long time to get there. And I don't know if there are many trainees in the audience. We were chatting yesterday just about the lack of broad surgical training now means that the technical ability within the eye maybe is dying. And then how do you deal with things when they go wrong? So I just be wary that when you look online and see the best case the person's done edited, it looks brilliant, and it's not like that in real life. I could show you many more cock-ups, but it's just keep going because you have to get over that learning curve, and only you know how long a learning curve is. Yeah,
no, that's a great comment, Steve. There's another comment on the chat which maybe might be best to reply to on the chat, because it's about an IOL choice one again. But it leads us, any more questions from Stratos or Louisa? Because otherwise it leads us very nicely onto Stratos's talk, because we've heard a lot about the Carlevale lens, and I think I've chatted to people who've tried it, but it's really good to get Stratos, because Stratos has got wide experience with this technique now, and we can something I haven't tried. I use the akreos and the Yamane now, and I use akreos for specific scenarios. But so Stratos, do you want to do your talk next? Thank you.
Yeah, thank you very much. Thank you for inviting me to be with you, and it's a great pleasure and honor to be with you. Yeah. So when I was in Southampton, Steve, the previous century, my teachers, Chris Canning and Adi Laff, taught me how to use the Malbrand method, which I used it for more than 10 years, since Agrawal presented his technique with the scleral pockets and the flaps. And I started to use that technique from March 2010 till March 2018. I have done more than 269 cases, and I'm going to divide this group of the patients into two smaller groups. The first 44 cases, I was using the same dislocate and the drop lens, but that was proven that it was a mistake, because I had almost half of the cases complications, such as haptic loss or broken haptic, tilt of the lens, and all of them, 21, I had to replace them. Being the haptics into the capsule for so many years, they become stiff and rigid. and once you pulse them, you break them, or they slip away from the pocket that you have placed them. So I decided since then to replace the lens in order to have less complications. So the rest 225 cases, I used the Alcon's MA60. And in this group of the patient, I had 6 retinal detachments. And why I had 6 retinal detachments? Because I couldn't be brave to make scleral indentation to find any residual, any pre-existing or new created retinal breaks. So I had 6 retinal detachments, and in 4 cases, I had haptic loss again. But the percentage of the complication was much, much smaller than the previous group. But I came to the conclusion when Carlevale came into the market. First of all, I don't have to use the same intraocular lens, so I have to use a new one. And once I have to use a new one, why should I not use the specially made for this purpose, the labeled intraocular lens, which is the Carlevale ones? This is a brilliant lens. It has a big haptic. It has a big optical part, which sits nicely behind a small pupil or large pupil or this distorted pupil. And then it has these nicely made flaps from each side that prevents tilting. And finally, these nice 2 plugs that you pull them outside of the eye and embed it into the sclera, providing stability for long, long time. So this is how I started with this technique. This is the same technique that Carlevale himself has proposed in the beginning. Again, 2 scleral flaps from each side. And then you fix the dislocated lens, you break it into the anterior chamber, you cut it in the middle, and you displace it with the Pacman's technique. And you go to the second step, which is the placement of the Carlevale. Now I have to stop that a little bit here. Now, I use the straight forceps from the nasal part in order to grab the plug, and then I pulled it out. And for the second haptic, instead of using a second pair of forceps to feed the initial one, I used the Sinski, which was a mistake. And the lens went into the eye, and I had to go again with the biome and to refish it, grab the plug and pull it out. So the plug comes out very easy, and then you cover it with the scleral flap and 7/0 vicryl suture. You see, it's easy. You don't know a lot of maneuvers into the eye. The lens sits in its place easily. What you have not to use is this kind of forceps, which may harm the haptics and the plugs of the lens. I used to use this one of Alcon's till I found out there is a special couple of forceps specially made by Chariot for the scleral fixated lenses. The curved one provides better ways of maneuver from the nasal part. So it's much nicer to grab the lens when you use the forceps from the nasal part. Carlevale himself has improvised his technique. Instead of using scleral flaps, he does this cut, and from one side and other side of the cut creates 2 scleral pockets in order to place the ears of the plug. And this is what I'm doing here. Nicely and easily, pockets made from the 2 sides. This patient had an ERM, so I peel the ERM and now go in and grab the hanging intraocular lens. I bring it into the anterior chamber, cut it in the middle, and then pull it out again with the Pacman's technique in order not to enlarge the corneal tunnel. And once the lens is out, I place the Carlevale lens into the cartridge. The same way you place an akreos adapt BNL lens into the cartridge, exactly the same way. And once the lens is in, you go in. Now I have the curved forceps from the nasal part, and I have better access to the plug of the lens, although the pupil is small and eliminates the viewing. It's always better to have a large pupil to see better clearly and better the plug, but you can manage with a small pupil too. So once the plug is out, you stop injecting, you find the plug, you grab it, and once you grab it, you continue injecting and pull out the plug from the scleral incision. Then, now is the trick and the tip. You have the second straight forceps, grab the plug and feed it to the other one curved forceps. So once you grab the second plug, you pull it out, and that's it. It's easy. The other thing is to place the ears of the plugs into the scleral pockets. Carlevale himself places, this is a nice place here. This is what I'm doing since I have started the technique, scleral indentation. Once you feel safe that the lens will remain there, no matter what pressure are you going to press to the periphery, you go and indent the periphery and find the pre-existing or the newly made breaks, and you cryo them or laser them. So eliminates the possibility of retinal detachment. And finally, you finish the case. Carlevale himself places some sutures to the scleral incision in order to eliminate the exposure of the plug, but I don't do it. I just leave the ears of the plug into the pockets and put one suture to the conjunctiva in its side. So I have done from March 2018 till November 2021 more than 130 cases. 3 of them were children. I had no major complications, few vitreous hemorrhages that has been absorbed in 2 or 3 weeks. No any particular enormous CMO that reducing the vision and complaining by the patient. So this is one of my very first cases. At that time, in the very, very first cases, I was placing the lens in a direction of 6-12. And here is the plugs that you can see 12 o'clock and 6 o'clock. And you see the big optical part of the lens, how nicely sits behind the pupil. Here is another case, a sunset intraocular lens, replaced by Carlevale. The big optical part of the lens nicely sits behind the pupil, and the 2 plugs covered by the scleral flaps. And finally, a traumatic cataract with iris base detachment, plugs into the pockets of the sclera in each side, and the optical part sits nicely behind the pupil, and a suture tenor vicryl placing the base of the iris into its place. Now, the 3 cases of the 3 children that I have operated, it was a 10-year-old boy who had open block trauma and retinal detachment. He initially operated with parsplanar vitrectomy laser oil, and then once the oil was removed, a Carlevale lens placed. Again, one of the very, very first cases. At that time, I was placing the lens in direction 6-12. You see the 2 plugs here nicely covered by the scleral flaps. The second case was a knife with open corneal globe trauma and traumatic cataract. You see the sutures on the cornea and the Carlevale nicely placed, sitting behind the pupil, and the two plugs under the scleral flaps. And finally, the third child, it was operating 3 years ago at the age of 13 months due to congenital cataract. There was no support to place a lens. So the pediatric surgeon said to me to place a Carlevale. And now recently, 3 years after the operation at the age of 4, here is the eye, how it looks. And you see the two plugs underneath the sclera sitting nicely. So here in Greece, we have published a study with many, many cases, which is in European Journal of Ophthalmology. And these 3 kids are published in seminar laser images as first cases. This is Carlevale himself. I really like him. And I always express my acknowledgement to him that his lens made a big difference to my surgery.
Fantastic, Stratos. Thank you very much. Can you actually stop sharing your screen, and then we'll
oh yes.
So we've got several questions. Just a couple of quick ones for myself. How big's the optic, Stratos? Is this how wide? What's the
6.5? 6.5.
Okay, so it's like the MA50, but it gives you that extra bit of
yeah.
And so I share your. It's interesting. You made the point we made before about relocating completely dislocated IOLs with haptics is not great. They often don't do very well. And Steve made the same point. And you also made the point about the pupils. It seems to be I've even pupil hoops can make your life harder. So I try to just get it, unless the pupil is absolutely tiny, I tried not to use pupil devices. Is that what you're saying as well? I think Stratos, because it just complicates things. Yeah, okay. Now, so we've got some interesting questions from the audience. Now, Cordelia says, you don't suture your scleral pockets, but you haven't found. Cordelia says, do you find the plug can rotate and mean lens is not sitting so well? But you haven't found that. Is that right? You just put the. I mean, I guess you have to be very careful with getting your pockets square and evenly spaced, but you don't find there's any rotation within the pockets.
I haven't found any rotation of the plugs and the ears of the plug. What other surgeons, especially the anterior chamber surgeons, afraid is that the erosion of the sclera, which covers the plug, and then eventually the erosion of the conjunctiva and the exposure of the plug. But this is the difference between the anterior chamber and us. They place the plugs in front of the ciliary body. That means in less than 2 millimeters from the limbus, because they don't want to touch the vitreous. They place the lens keeping the vitreous without vitrectomy. So they have the lens in a closer position to the cornea. So the tension of the lens may pushes the plugs outwards, and they create some kind of erosion. Mm-hmm. I place it 2.5 to 3 millimeters from the limbus behind the ciliary body. So the lenses don't have any force towards the sclera.
Yeah.
They don't push the cover of the ears of the plugs, and that's why I don't have scleral erosion initially and then conjunctival erosion.
That's very interesting. What do you find? So you basically find that in terms of refractive outcome that you end up with pretty much what you aim for when you.
Well, I always choose the lens that provides me -1.
Okay.
Because I put them farther behind, so I make a hyperopic diversion. So
okay.
in order to have emetropia, I aim for the lens that provides me -1.
Okay, that answers one of the questions: is what A constant you use. So it's apparently 119.1 is the A constant for 1.5 millimeters. So what a constant are you using? I guess that's a good question.
Well, I don't know about the constancies because we have a nurse that doing the IOL master, and I always say, bring me the -1.
Okay, okay, that's very good. And you must, another relevant question is, if you do a 3 and 9 o'clock versus a, you know, a more horizontal, sorry, a horizontal type lens, well, actually, I guess you'd always slightly decenter it to, just like we do with the Yamanes, you know, so it's like more like 230 and 730 or 830 rather, versus vertical, because obviously the eye's wider horizontally. Do you find, so what, so you go horizontally now, if you haven't found any difference in?
No difference at all. I think the optical part, it's that large that prevents you from any kind of minor dislocations.
But in terms of IOL position, I guess which is, I suppose the question is, which do you prefer? You prefer horizontal now?
No, yes.
Near horizontal.
I'm doing horizontal now.
Okay, right. So lots of questions. So Carlevale is a hydrophilic lens. Pacification.
It's hydrophilic. It's hydrophilic. That's why it's very soft.
But
no,
no,
so far I didn't have any kind of haziness, or so far 3 years and a half.
Okay. No. Have you used gas in any of them, Stratos?
Sorry.
Have you used gas, or have you had to use gas for detachments?
I have used gas in a couple of cases with no major problems. I mean, gas came into the arterial chamber and then went back. The lens hasn't dislocated. Haven't used silicone oil yet.
Yeah.
Thank God.
Okay. Well, another question is, what's the injection technique? Is it a squeeze, a screw, or
no, squeeze? It's the same cartridge that we use from the Bose and Lomb akreos intraocular lens.
Which is a so
plastic, one use injectable.
So it's basically a plunger which you push.
Exactly.
Yeah. Okay. Right.
You press it in.
So Steve, are you tempted to use this technique? You're muted.
So yes and no. Things that I don't like about it are special order lens. You only get one lens as well, don't you? Which I guess you want to be sure you can get it in one go, because they won't send two because it's obviously bespoke. I don't know how much it costs, but it's certainly more than a ZA9003.
It's not expensive.
No, but compared to a ZA9003, it's probably significantly more expensive. So I like the look of it. It's just when you're doing something that works really well, you're getting good results with something that's off the shelf, that's cheap. I need a good reason to change. But where it may be a benefit is in an eye that is very large. So I would certainly consider it for a high myope. But I need to go to a few more of the lens courses that we run together in London to practice using it, because I've never used it before.
Cordelia's just said that she orders two and they're £70 each, I presume. I presume that's £70 each, in the UK at least. Right. Yeah, so there's another question. I am from Assam. I had an issue with the first plug rotating oddly during implantation, and the entire lens rotated, so I had to re-rotate it in the vitreous. How do you avoid this issue? So yeah, so rotating during the second haptic fixation, presumably. Can you see that, Stratos?
Yes, I see that. This is a problem when you have vitreous into the eye. Once you have removed the vitreous, I don't think that you have a problem.
Yes, I don't know whether they mean the vitreous or whether they just mean the vitreous cavity.
To rotate the lens into the vitreous cavity, there is no damage at all. I mean, you rotate it.
Yeah. Sorry, you were using, interestingly, Scarioth IOL forceps, which I agree are very nice because of the short curvature. MST also make curved forceps. So the Scarioth forceps they're designed to grasp a haptic longitudinally. So they've got a groove in the middle of it. Yeah. Is it specifically that aspect of them, or just the curved aspect you like?
I think the curved aspect. The other one, I would prefer a kind of forceps that will be coated by something plastic in order to be more gentle for the haptics, like a slice of silicone, whatever plastic that can grab the haptic without damaging it.
So there's yeah, so the MST ones have got, you can actually choose the orientation 90 degrees or the same as the gripping action, and they've got serrations on them. Because Steve, what do you use, Steve, for Yamane technique suits forceps? You're muted, Steve, sorry.
D.O.R.C rated in
So
grippers, the 23 gauge.
So they're complete straight ones. They're basically for, yeah. And you like them because of these serrations, which are good for grasping.
Yeah, and it can grip at the end. So when I first started, I used just using ILM peeling forceps because I basically want to use whatever we have lying around as a default because it's just more efficient and cheaper for the NHS, as we trying to save the NHS. But the difficulty with those is because they grip at the end and not, during the shaft. You can then end up going beyond the haptic and grabbing iris, or so that the serrated grip all the way along. So wherever you're gripping, they grip. I've tried the max grip, but I just couldn't. It didn't feel secure to me. So I like the D.O.R.C.
Yes, I much prefer the short curved ones. And somebody, Simon Kolb said about the Packer Chang forceps. I think, are they not MST? I might be wrong.
Yeah, they are. They work very well as well.
Yeah, yeah. And another comment from Rubina saying, I use Shah extra grip serrated forceps by Rethread to grip Carlevale. So again, the Shah extra grips, I think they're the ones with the oblique action on. They're designed for very tenuous, rough membranes, aren't they? Which makes sense. Completely makes sense. Yeah, yeah. So you, it sounds like Stratos, you use this technique completely now. You wouldn't use any other technique for a secondary fixated IOL.
Once dislocated IOL, I use Carlevale, nothing else.
Yep, yep, okay, right. Yes, no, it's interesting. It seems to be because and
that was a technique that I learned from the first case. Yes. Once I used it once, I said, "This is."
Yeah, yeah. Because I tend to use, so this would be interesting to get Steve involved as well. So I tend to use akreoses for when you've got very abnormal irises, which are very mobile. I also use them for big eyes, or for sclera, where the sclera's trauma eyes. So what technique do you not use when you can't use a Yamane, Steve? What technique do you go to when you can't use a Yamane?
So I've used the Artisan, and I would, as I said, I had that one case where I should have just used an ACIOL because she had a terrible head tremor. It's almost impossible to do. Yeah. I'm tempted by the Carlevale, especially for the big eyes. So that's something I'll have a think about for a big eye. But I've done, I've been doing this since 2017. So the reality is I've done Yamane on pretty much every secondary IOL that I've done. And I've encountered one problem with a twisted lens in a myo that I didn't see coming. I've had the problems with one Marfans, but not the others. It's generally, I mean, I have to say it just generally works for me. And yeah. You saw the unedited case, it takes 2.5 minutes to do.
Yeah, yeah.
So it's not a long.
I think this is also, there's one more question, which basically I think we'll finish off with, but is that practice makes perfect, doesn't it? So you'll be both very slick with your preferred technique and having a preferred technique, which you get very good at. So the question is, the first you did this first 3, which is this in 1 week, which is obviously unusual cases, but 60 minutes at the minimum compared to the iris claw, which takes 20 minutes. But I guess probably you've probably done an awful lot of iris claws, and are just learning the Carlevale, and any techniques takes some practice with to get slick with it. And that's what the point of these. So one more. Actually, there's 2 more questions I want to ask. What's the cystoid rate in the Carlevale? But I think you've already said this, Stratos. You haven't really seen that as an issue, have you?
It's very, very little, very limited, because the shape of the lens is to stay away from the iris, and I place them away from the ciliary body, so there is no chronic irritation of the uvea, so I don't get any CMO.
Have you used it in Marfans, Stratos?
So far, no, but I have a case that I would like to share with you. I used it in a totally aniridic and aphakic lady, 85 years old, after a trauma. And initially, I was planning to place the lens, and as a second procedure to place an artificial iris. And interestingly, how the lady after the Carlevale hasn't got that irritating photophobia. I don't know it's whether it's the flaps that stop the light or the big optic part of the lens that stop the lady complains by the excessive light. So we stayed with the Carlevale. We didn't go forward for the artificial iris, which is really interesting.
Yeah, I mean, they are interesting, aren't they? Because sometimes we think they need an iris, but in actual fact, because especially the congenital ones, they haven't had one forever, and I've got one lady I've recently done where I've done an iris in one eye and not in the other eye, and there's not a huge difference, but interesting. So I think actually, sorry,
could I just ask what power range do they come in?
What, the Carlevale?
Yeah.
Any rates up to 28 and lower to 6, 8.
Okay.
You have all the range.
No, we're bang on time basically. So I think James is probably in the background somewhere. So I'd like to thank Steve, Louisa, and Stratos for their fantastic presentations with great technique. And and thanks for giving us the opportunity to have this symposium, James. I'll hand over to you.
Yeah, no, thank you very much, David. Thank you to all of the speakers. I'd just like to echo that feedback. I think the videos, the techniques, and the way these have been presented is a really good practical examination of the options available to surgeons. And the questions are great because we've seen that there are people both who are curious to try some of these new techniques and also people who've performed a few cases and are looking to gather some further input for further experience. So no, thank you very much to all of you as speakers. Thank you to you, David, for moderating the session so nicely as well. Great input from everyone. So thank you for that, and thank you to all of the attendees for spending a precious hour and a half of your evenings online to listen to this session. And I hope, David, you get reconnected to power soon. I feel particularly tough for that. So yeah, hopefully. Hopefully we get to see you at a future session in a more domestic environment, shall we say?
Well, at the university, but about to go home to my house at 4 degrees C and pitch darkness. But in any case, hope nobody else is in the same situation, which is why I'm wearing so many clothes. I'm getting ready for the journey home. Well, great. Good night, everybody, and thank you for listening.
Yeah, thank you very much, everyone. Thanks. Good night.
Good night. Bye-bye. Bye-bye.
Bye.